Welcome to Voices in Value-Based Care. I'm Matt Fusan. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. On this program, we explore stories from the field about how real organizations are dealing with this change. As always, you can follow the show on Twitter at #VoicesInVBC and follow SPH on Twitter at SPH Analytics. On the program today, I'm talking with Gina Bruno, Vice President of Value-Based Care with naviHealth. Welcome to the show. It's great to have you.
Thanks, Matt.
We're going to be talking a lot about value-based care, specifically bundled payments, kind of how they've evolved, where they're going. But before we dive into that, can you tell us a little bit about yourself?
Sure. So as you mentioned, I'm the Vice President of Value-Based Care at naviHealth, which is a post-acute care and care transitions company. And at naviHealth, I'm responsible for really leading our thought leadership and strategic direction with respect to value-based programs, particularly with Medicare fee-for-service innovation. Most of that, as you alluded to, is related to bundle payments. So programs like bundle payments for care improvement and bundle payments for care improvement, or BPCI advanced. I've been with naviHealth for a little over 5.5 years, but surprisingly, I'm actually not a healthcare lifer. So my career before naviHealth was in strategic change management and transformational change. I spent close to a decade in Washington, D.C., working with the federal sector on major change initiatives after Hurricane Katrina, actually. Made a little bit of a transition point after my career there into healthcare, going to Vanderbilt University for my MBA, focusing in healthcare and healthcare strategy. So a very short-term career in healthcare formally, but as I tell folks, I like to think my time in healthcare started actually before I could read. At 5 years old, my grandfather was admitted to a nursing home where he spent the next 6 years there, and my mother served as his primary caregiver in that capacity. So in many ways, my transition to Vanderbilt and to naviHealth was a little bit of a homecoming and a chance to support seniors professionally in a way that we did as a family when I was much younger.
Excellent. Thank you. And it's interesting to be able to bring perspectives from outside of healthcare into healthcare, right? Sometimes us lifelong healthcare people get a little bit tunnel vision, so it's always nice to bring that in to healthcare. And your former experience before healthcare, very pertinent because all we're talking about is change in healthcare, right? So it's significant. So, before we kind of get started, I always like to set the table for the listeners a little bit. And could you tell us, very basic level, what is a bundle, a little bit about the history, and maybe an example of a common bundle that's out there?
Sure. So bundle payments are one example of alternative payment models that have been launched really in the past decade or so. There were some early bundles about 20 years ago, but a lot of activity in the last 8 to 10 years. And when we talk about bundle payments, what we're really talking about is an episodic model in which costs are reimbursed for an episode of care. What I mean by an episode of care is that this is typically oriented around a given clinical condition or procedure, and it is time-bound. So there's a starting point, and that starting point is often an acute hospital admission, and the time included in that bundle typically includes some number of days after a hospital admission, maybe 30, 60, or most frequently with CMS, a 90-day episode of care after that admission. When we think about the episode, we're thinking about a variety of services and interventions that a patient, or in this case, a Medicare beneficiary, might experience with economics around something typically called a target price. And so what the target price is using years and years of historical data, we've been able to determine on average what this acute admission and post-acute episode is likely to cost. And participants in these models have an opportunity to, quote, beat the target price, if you will. Now, if these participants can deliver high quality care at a lower cost, there's typically an opportunity to save and retain the savings between the target price and your actual cost. However, many of these models are two-sided risk models, which means that a participant that delivers very expensive care or poor quality care may find themselves above that target price and would have to then repay CMS for a Medicare model or repay a commercial insurer for a non-Medicare model for any cost in excess. That's the high level. The models in terms of goals are really focused on the triple aim, improving the quality and outcomes for the patient that is experiencing that clinical condition or procedure, and then decreasing excess utilization or cost on the cost side of that equation. There are wonky details around all of these models, and far more detail I will spare you and the listeners, but they can be quite complicated. And in the way of an example, I know you asked, joint replacement is probably the most common example, the one that people go to most frequently. So a total knee replacement, what you need to do there in that procedure, your time afterwards. But I'll tell you that those bundles can really expand into maybe less conventional areas like congestive heart failure, sepsis, pneumonia. And we do see a lot of that in the BPCI Advanced program.
And I think that's interesting because I think, like you said, most people think a bundle as basically joint replacement. That's what everybody thinks of. And it conceptually makes sense because it's been done so many times. You got all the data. It's all these kind of new expanded ones that are getting a lot more interesting. And you talked about a couple of CMS models. How prominent are bundles right now with non-government payers? Is it expanding at the same rate as the CMS models, or are they lagging?
Yeah, it's a great question. I think about this a lot, especially as naviHealth was acquired by United Health Group and Optum in 2020. So I do think about this pretty frequently. And I like to think that the relationship between CMS and commercial payers is somewhat symbiotic when it comes to bundle payments. So in some cases, you see commercial insurers following CMS's lead. So thinking about Medicare Advantage, for example, you do see many large health insurers beginning to build or building upon bundle payment models around things like joint replacement, spinal fusion, cardiac bypass, often looking to CMS for some inspiration in how they structure the pricing, benchmarking, and so forth. But on the other side, you see commercial payers leading in some areas. I think this is most prevalent in labor and delivery or cancer care, where you're seeing commercial payers think maybe less about a Medicare or Medicare Advantage population and more about the commercially insured or even Medicaid populations, and thinking about how the same bundle payment construct can apply there. It's a pretty interesting conversation to me. Maybe it's just me, but you think about the ability to incentivize behavior change, especially for specialists. And bundle payments, whether it's CMS or it's a commercial insurer, present an opportunity to really connect with the specialist community and be able to drive behavior change in that way. I think back pain is going to be a really interesting place where you can see a bundle payment as potentially, I don't want to say the only way, but a pretty powerful lever to encourage the kinds of activities around a surgical intervention that can lead to improved outcomes for patients. So I think we'll see more of it. Maybe slow going, but I think we'll see more.
Right. So then here's the $1 million question that we talked about, and there's many different perspectives and angles, but now we got, like you said, 8-10 years of experience with bundles. What's the verdict? Are they successful? And as you and I discussed, I initially went to the cost savings being a metric of success, but there's really higher quality, most importantly, patient outcomes, right? And all those things. So love to know your thoughts on where we stand at this point with the binary question. And unfortunately, it's never a black and white answer of success or not successful.
Yeah, that's right. It's definitely a big, it depends. It depends what you're asking question. But you're right. Success in these models takes a variety of forms. And I would say overall, the story is somewhat mixed. And so at the highest level, as we think about the original BPCI model, BPCI Advanced, DJR, the oncology care model, overall, we see a couple of trends. One is that utilization tends to go down. So we see things like reductions in length of stay in a skilled nursing facility, or even admissions to a skilled nursing facility. However, that hasn't necessarily correlated with meaningful savings to Medicare. We see that in some cases, like comprehensive care for joint replacement, that is an example where we've seen statistically significant savings, but it hasn't necessarily translated in that way on a broad scale. On the quality side of the equation, it's a very interesting phrase that I like to share, and that has been no statistically significant decrease in quality, which sounds like sort of a neutral kind of meh statement. But
Right.
I think it's important to note, as we think about being able to decrease excess or potentially unnecessary utilization without compromising quality, I think is actually a testament to the efficacy of this model. Of course, we'd love to see costs come down and quality shoot up, but to be able to move one side of that equation without adversely impacting other is pretty telling, given that we have about 8 or 10 years of experience, but still that's all we have. And so not seeing those adverse impacts is pretty powerful. What I'll share is that you do see some pretty strong examples of success, particularly in joint replacement, both in the CJR model as well as in BPCI model 3, which takes us back some years, but that was a model that focused on the skilled nursing facility and episodes of care that began there. Both of those models showed statistically significant decreases in cost per episode, as well as a lower length of stay for BPCI model 3. To me, it's a good sign, and it's a promising sign that these joint replacement models have shown success. The next step for us is going to be how we translate that same success to some of these medical conditions, heart failure, COPD, pneumonia. We have to start driving similar meaningful results, and we have to start getting deeper into the data around efficacy beyond the claims-based measures where we typically go, unfortunately, at this point.
Right. So I have limited experience with bundles previously in my career, specifically CJR and the oncology care model. So know kind of enough to be dangerous type of concept. But when I was working on those, I know a couple of the big challenges were who controls a bundle whenever it crosses multiple care settings or providers that are involved. And then the other big one was, and it ties hand in hand, is care coordination and who becomes accountable for care coordination. Tell us your thoughts on those, how they impact success, and kind of what you've seen in your experience.
Yeah, care coordination is the single largest challenge, I think, in an episodic model. I was telling some family members, I said, you would think your loved one is leaving the hospital, they're going to have the information they need, their PCP is going to know, the nursing facility or home health agency they might need, they're going to know all the information they have. That may be the unicorn case, if you will. And so often a patient may be leaving the hospital, their PCP may have no idea they've even been in the hospital, let alone what has happened to them, what medications have changed, where they're going. And then likewise, if they need post-acute care, such as a SNF or home health agency, that provider often has very limited information, very delayed information about what has happened to that patient before. And all the while, the burden is falling on the patient himself or herself or the family member to try to sort of self-navigate, if you will. And any of us that have had experiences with the healthcare system directly or for a loved one can tell you, even working in this space, it's really confusing and complicated. I don't know that we've solved it yet, but I do believe that bundle payments create this forcing mechanism to improve that communication, not just the timeliness of it, but also the quality of it. So take, for example, a loved one who has had a condition in the hospital and now needs to go to a skilled nursing facility for a period of time. If you're like me, I would say, well, geez, doc, how do I know which one's good? That information is still tough to find. And you think, gosh, it shouldn't be so difficult, but yet here we are. And so the issue around care coordination is something that we take very seriously in the work that we do in bundle payments, focusing very specifically on each of those transitions, hospital to skilled nursing to home, and making sure that in those most vulnerable times, we're able to provide that information and connectivity between providers and members of the care team and really support the family caregiver and the patient in that process. We're getting better. I said all of us, the collective we, working in these models, but still a ways to go to overcome those challenges.
And just through personal experiences, family members that have had cancer in one cancer center in Pennsylvania versus another cancer center in Florida. and two drastically different experiences. In Pennsylvania, it was coordinated through the oncologists. Before my mom left the house, here's your next appointments. They're scheduled this. They'd call and check in and everything else. In Florida, it was, here's your information. Go do what you got to do. And especially that disease and how challenging that is to then say, okay, you're on your own. Luckily, in both cases, there were very capable spouses. But what it made me realize was, what if there wasn't a very capable spouse involved? It gets scary really quickly.
That's right. And it really, I think the experiences that we've had, over the past year and with COVID and seeing all these changes, it really highlights the need to think about how we support not only these vulnerable times, but particularly vulnerable patients and members of our community as well.
Right. So as we were prepping, we were talking about voluntary versus mandatory. And we had a fun little conversation about CMS's history of going back and forth on that concept over the past, call it decade or so. And where we are currently is more of a voluntary basis. But of course, we have a new administration coming in. What are your thoughts on one, voluntary versus mandatory, kind of pros, cons, but then also, what are you thinking the new administration's approach will be, knowing that it's a little bit of a crystal ball type of question I'm forcing you into?
Yeah, no, this is a crystal ball question I like, because I feel pretty confident in saying that I think we will see mandatory models. Taking a little bit of a walk down memory lane, you'll recall that the Obama administration launched mandatory models around fractures and cardiac care that were ultimately pulled back under a Trump administration. And I think we'll see that again, maybe not in its exact format. This is not Obama 2.0, but CMS has already indicated that they are working on a mandatory bundle payment model to follow BPCI Advanced, which will conclude in 2023. So I think there's already work there, a little bit TBD around exactly the shape of that model, but I do think we will see at a minimum one, but potentially others. I think we talked a little bit at the beginning around some of the places where health plans may be leading some innovation around places like spinal care, back pain. And I think you may see CMS take a cue and really look to build innovative models that can drive change in a way that others may follow suit. Where Medicare goes, often others will follow. And I think we will see some of that activity. And the reason I feel so confident in that is not just because CMS said it, but it's because the mandatory models, they can address some of the challenges that we've seen in voluntary models with respect to selection bias or benchmarking. We're able to randomly identify geographies, but also thoughtfully identify geographies to participate, to really think about areas where variation is excessive, or there's opportunity for improvement. So I do think we'll see them. I don't know that it means that we'll see the end of voluntary models, though. I think we'll continue to see voluntary models. We'll continue to see other advanced alternative payment models around primary care, population health. But I think back to a MedPAC meeting last fall of 2020, where they talked about this exact topic. And one of the commissioners said, part of the problem is that voluntary models haven't made it uncomfortable enough for people to sit out. So you either need to make them mandatory, or you need to make it a lot more uncomfortable to avoid participation. So I think you'll see mandatory, and I also think you'll see voluntary that includes additional incentives to participate and maybe a little bit more discomfort for those who are still choosing to stay in that fee-for-service boat.
And that's always been the interesting part, and part of the work I had with previous bundles was helping organizations decide, should we do this or should we not? And then it becomes a very self-selecting group of people. The only ones that volunteer are the ones that feel they can do well, and to do well, you're typically a little bit more advanced along all the components that make you successful, because so it's not bringing along where the most challenges are. I think there needs to be more uncomfortableness, for lack of a better way to say that, as you said, for staying in fee-for-service world, right? There's going to need to be a push from there somewhere or another, and mandatory may be the way it goes. But I think, to your point, this upcoming decade, listeners and everybody out there should start thinking sooner or later, and probably sooner, this isn't going to be a choice. This is going to be forced on you. And one of the things in some of the previous mandatory models that ended up either getting canceled or changed back to voluntary was it's about a 6-month, 8-month lead time. You get told this is coming and it's coming. And if you haven't already started preparing in some way, shape, or form, you are in big, big trouble. So that was a big part of what we were trying to convince everybody is you can't wait until you're told to do this or else you're going to be in big trouble. You got to start getting the muscle memory going now and the things in place.
That's right. The burning platform is your step one in your change management process. So you are right to advise
there you
that
go.
way.
That's right. That's right. So, we talked about COVID-19 pandemic. Of course, would be strange if we didn't at this point in our country's existence in the world. We're talking in December. This will be out in January. We feels like we're starting to see the light at the end of the tunnel with the vaccines. So for reference, we're recording this about 2 weeks after they've been approved and started just this week being administered. So, what do you think the impact on healthcare in general will be of COVID-19? Kind of short-term and long-term, and feel free to kind of expand on your long-term thoughts. Because I think that is going to be, one of this is going to be one of those events that truly has long-term impacts that may not have come about as quickly if it wasn't for a forcing burning platform again, like COVID.
Yeah, absolutely. It's a good time, I think, to feel optimistic. It's going to still be a long road, but optimistic enough to see that the light at the end of the tunnel is there. But there's going to be, in my opinion, quite a bit of reckoning as we get through that process. So I'll start with the short term. And I think the most prominent impact that I have seen in the short term has been delayed care. Now, we have seen inpatient volumes in hospitals decrease anywhere from 20 to 30% over the course of COVID. Outpatient volumes oftentimes decreasing at even higher rates. And we know with that there are patients who are likely postponing necessary care, postponing interventions or screenings related to chronic conditions. And it is an almost near certainty that we will see patients present in 2021 or beyond with more severe aspects of their disease. And I think that we need to be prepared for that. It remains to be seen exactly how significant that impact will be, but undeniable that impact will be there. In the short term, we'll also see continued flexibilities, waivers from CMS around things like telehealth.
Good point.
And that's going to be great. We'll need those, at least through the summer. Very much to be determined how many of those stick, especially those like telehealth that would require congressional intervention. In the long term, I'll leave you with just a couple of thoughts here. I think that COVID-19 is forcing us appropriately to get really uncomfortable. And there are two examples that I'll share. One is around end of life, and one is around health equity. COVID-19, we have seen the headlines. People are coming to the hospital and they are experiencing end of life situations that are heartbreaking, and saying goodbye to loved ones on an iPad, if there's one available. We have to do better as a healthcare community and as a country around having those conversations that honor individuals and their end of life choices, and building a community that supports them, so that we're not finding a nurse's iPhone to call a loved one. That cannot be anyone's wish. And then with respect to health equity, it has become abundantly clear that Black, Brown, and communities of color are disproportionately impacted by COVID-19 and disproportionately impacted in healthcare in general. The systematic racism that we have exposed as a country plagues healthcare just as much as any other sector. And I mentioned reckoning and uncomfortable conversations. This is a place where we now know that the data is there, the outcomes are different, and we have an opportunity to do better. As an industry, as a community, in models like bundle payments, we need to be seeking out better data, being more thoughtful about how we impact the patient experience, and really looking quite critically at how we can impact disadvantaged communities as we move forward as a healthcare sector. it's not going to be just bundles, just models, but really full-scale change, I think, in those two areas and many others.
Yeah, and we've been seeing, so I've been really interested from a care management, care coordination perspective, all the non-healthcare related components, right? So as we all know, most of what drives health happens outside of the healthcare setting. In the common term that everybody knows, social determinants of health. And that's been out there as a concept for a while, but it hasn't gotten a lot of traction except for in little certain pockets. And I am thinking and hoping that this helps push that forward. And I can tell you just in conversations that we're having in the market, there are more and more people asking and looking for that data to be integrated into solutions. So with you, I also am hopeful that this is a bit of a turning point, because it's near impossible to get somebody to follow the doctor's recommendations if they can't actually follow the doctor's recommendations, right? If I can't do it, you can yell at me every week. I can't do it for various reasons. So that's going to be interesting. Right. We got about a minute left, and I'd love for you to tell us, and I know I'm only giving you about a minute, but a little bit more about what naviHealth is doing and the work you're doing there.
Yeah, absolutely. So we've talked today about bundle payments and value-based care, which is a large component of what naviHealth does. But we also partner with hospitals providing technology and with health plans providing post-acute care and care coordination support in Medicare Advantage. Today, we serve about 6 million Medicare Advantage and ACO members, supporting nearly 900 hospitals and nearly 100,000 episodes of care in BPCI Advanced and other models annually. So very broad participation. But I'll tell you just a couple of things I'm really excited about. One is through our post-acute care management, we've been able to achieve 1 million extra days at home for seniors last year. That makes me incredibly proud. Yeah, incredibly proud, really supporting folks through that post-acute journey. And as we look ahead into 2021 and beyond, we're really focused on how we enhance the experience for seniors once they return home. How do we give deeper, more supportive care, both through traditional home health and through other supportive services that may benefit patients once they're home and back in their community, maybe doing what we can as a company to support some of those issues that go beyond the hospital setting. Really excited there and excited for all that we continue to do to help seniors live a more fulfilling life.
Excellent. Thank you. And as always wish we had more than the time allotted. I think we could get into a lot more interesting conversations, but thank you so much for joining us today. Thanks to our audience for tuning in. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInBBC, and be sure to follow SPH on Twitter at SPH Analytics. Of course, I'd love to hear from you on LinkedIn as well at Matthew Fusan. And until next time, this is Matt Fusan bringing you Voices in Value-Based Care You Should Hear.